I think a lot of that comes down to is physicians need to be empowered to help advocate for change and to what do we think is good systems. Because I think the doctors themselves are not necessarily we would like it to be more patient friendly for people to have better access to care. Those are why the reasons we went into medicine.
Hey, VetFolio Voice friends! Thank you for joining me for an episode that is near and dear to my heart. In this episode, I am beyond thrilled to introduce a very special guest, my sister, Dr. Lisa Hayes. Lisa is not a DVM, she's an MD, but prior to going to med school, she spent some time with me in vet med, and because of that, she brings a little bit of a unique perspective, having spent time in both worlds. Although, I'll be honest, I'll never really understand why she was so determined to work on people. Lisa has known since she was still in high school that she wanted to go to med school, and she's currently working toward a fellowship in pulmonary and critical care. Together, we had such a good time examining kind of the parallels and divergences of our two worlds of medicine, and really identifying that despite our different patients, we can always find common ground in just the shared ethos of prioritizing patient care and well-being. For example, we talked about the importance of a good history and physical exam as a starting point for any diagnostic and treatment plan, and I loved Lisa's perspective on how her time in vet med helped shape the way she approaches this part of patient care as an MD. We also talked about making targeted diagnostic and treatment plans and being conscientious of not putting our patients or their families through any unnecessary tests or adding unnecessary costs to the bill. And with Lisa pursuing the specialization of pulmonary and critical care, we walked through the role of specialization in vet med versus human med and kind of the differences between the two fields and pros and cons of specialization versus, more general approach to medicine. And Lisa's also very passionate about process improvement in her area of medicine. So that gave us the opportunity to talk about the role of process improvement and its importance in providing effective patient care, which ultimately keeps us medical professionals coming to work every day. It keeps our spirits and our morale up. On a more personal note, sorry, Lisa, I'm going to spill a little. Lisa's my younger sister by almost a decade, and I've watched her grow up. So sitting here listening to her speak as an MD and hearing just her intelligent and balanced and compassionate perspective, I'm just so impressed with the doctor that she has become, and I loved having the opportunity to bring her perspective to all of you. Okay, I'll stop gushing there. Let me introduce my sister and let you hear it from her. Dr. Lisa Hayes grew up on the East Coast of Florida. She earned her bachelor's degree in biomedical sciences from the University of Central Florida in Orlando in 2016. And following her passion for medicine, again, in humans, I'll never understand why, she pursued medical school at the University of South Florida in Tampa, graduating with her MD in 2022. Following medical school, Dr. Hayes decided to continue her training at USF, where she's currently a second-year internal medicine resident and was recently named chief resident. Her area of interest is pulmonary and critical care, and she's currently in the process of applying for fellowship in this area. Alongside her clinical responsibilities, she's deeply engaged in medical education initiatives and has an interest in quality improvement. Outside of medicine, she enjoys water sports, traveling, and anything adventurous. I can vouch for that. That is absolutely true. Let's go ahead and get into our episode. I hope you all enjoy it.
Join more than 100,000 learners just like you. VetFolio is one of the largest providers of continuing education for the animal health community, offering more than 500 race-approved CE courses. Earn veterinary CE anytime, anywhere with VetFolio. Subscribe today at vetfolio.com.
Well, we're doing another recording here in the Gainesville studio, which is so exciting because we worked really hard to make this studio, kind of cute and inviting. And it's so fun when we get to use it. Plus these recordings in person. They're so much fun when you can just sit in the same room and be face to face and have that interaction. And this is an extra exciting recording because I'm joined by my sister, Dr. Lisa Hayes.
She is a physician. She's an internist about to finish her residency. So, Lisa, thank you for letting me rope you into this.
Yeah, no, thanks for having me here.
Basically, what we're here to do, I think, is have the conversations that you and I have all the time about like, what about this and what about that? And we kind of started having that conversation before we hit record here. So we had to say like, stop. Let's hit record. Because there are so many differences between veterinary medicine and human medicine. But before we kind of go down that road, can we go like the Wayback Machine here to when I first graduated and you came and you would work in the clinic with me before you ever even went to med school?
Yeah, so back when I was still an undergrad and you had just finished vet school, started your first job, I was able to come up and work with you in clinic, kind of get some hands-on experience. In human medicine, they don't let you do as much hands-on without the credentials. So it was always fun to come and actually get to do a little bit more things and be involved and see a lot of the care. And a lot of it, is very similar to what we do in human medicine. And especially now being able to kind of look back, I think one of the things that took away was how much, one thing they tell you pretty early on when you start med school is 80% of your diagnosis is history and physical. And seeing how much in veterinary medicine you really have to rely on that skill because you don't have a lot of extra data. Like we in human medicine, I think kind of take for granted sometimes the amount of extra tests and data that we can order that you guys just don't have the access to or the ability to order on every patient. So really just kind of getting that your diagnosis anchored in how you're interacting with the patient and how they're presenting and what that looks like.
Oh, I got goosebumps. Like, yeah, because and I do remember you and I talking about that a lot when we were working together of like, it was like, well, why not do this test? And it's like, well, we can't because we're out of money. And so we just have to like work with what we have and see what we can figure out. And we're lucky in vet med that our patients are very resilient. And they can handle a lot of stuff. But yeah, it's just a really rewarding relationship that you develop with your patients and with your clients. I can't so much relate on the human med side, but I know certainly like when I watch medical shows on TV, which I recognize are not an accurate depiction, but when they're like, yeah, just order, like all these tests on every patient. And I'm like, you can do that? That's what do you do with all that information? Like the answer is just there, right? Which I'm sure it's not.
No, there's a lot of times that we just like to order data because it makes you feel more comfortable, like you're doing a thing and you're working it up. And we actually have the opposite problem of like trying to train our trainees and doctors and our attendings are always telling us, what are you going to do with that piece of data? Is that going to change your management plan? And if it's not, that's not cost-effective medicine and we need to stop ordering all of these extra things. But when you're starting out and the textbook says, if you're diagnosing this, you should order this test. Sometimes we just blindly order it because that's what we were taught. Now looking back, as you're actually kind of developing more of your clinical acumen, you're like, do I really need that test? Or do I really think it's this regardless? And whatever that says isn't going to sway my opinion. I'm going to treat them the same way. Maybe I don't even need that.
I love that. That's a huge part of vet med of like, is it going to change your plan? And if not, it's not that it's wrong to run it, but we need to make sure we're communicating that to the pet owner to say like, hey, I'm doing this because I'm the vet and I want to know, but it's not going to change my plan. So, are you comfortable with this? And many times pet owners are, but certainly if we have a financially limited case, it forces you to get creative and really say like, really drill down on those differentials and say, what test is going to give me the most information off of one single diagnostic?
We actually just did an exercise in one of our didactics, which was kind of fun. They gave us like a pretty straightforward case. Like it was a guy that came in, he was passed out in his yard after working in yard work and, had a syncopal episode. And it was like, okay, what tests do you want to order? So everyone's going through, well, your differential could be this, it could be this. You should order an echo. We should maybe think about getting like, is this a seizure? Is there some kind of neurologic problem going on? And it's like common things are common. He was hot, he vasovagaled and passed out. Like, so we've calculated how much we actually spent on our very comprehensive workup. And it was like, you spent probably $10,000 to give this guy some fluids and send him home.
So that's interesting. It's funny when as soon as you said that, like I feel like whenever they gave us a case like that in vet school, it was always Addison's disease, always. But which is funny because my mind does go to Addison's disease a lot now. But I like on the one hand, I think it's a really good lesson to say, this was a really simple thing that happened and you can diagnose it and treat it simply. On the other hand, I would almost feel like having that information as the person who passed out might be nice to say like, you didn't have a seizure, you don't have a heart problem, your blood pressure is fine, everything's okay, which that's another thing that we found was unique from vet med and human. Like we do blood pressures as a separate service. You would have the blood pressure anyway. So like on the one hand, were the tests valuable because you were able to rule out all these scarier things? Because would an invasive vagal be more of like a diagnosis of exclusion?
So it's kind of, we look at a lot of like pre-test probability and like given the history and given the story that you're having, and you have some basic lab data that we would probably get on anyone. Is this likely to be cardiogenic or neurogenic based on the history you're getting? So it's really relying, going back to that kind of thing they always teach in the beginning, is 80% of your diagnosis is going to be in your history and physical. If you don't have a strong sense of like, this is really what's going to be, like a lot of times you're going to spend that money and it's going to be negative, where simpler tests you can order first, like if we would have gotten orthostatic vitals on this guy, so have them change, because we can do blood pressures on everyone at any time, having them just check them from like sitting to standing. And if his blood pressure dropped, okay, now I've got some objective data that maybe he's a little bit volume down. We could give him some fluids. The story really checks out. You ask any questions that'd be concerning for seizures and really rule that out with your history and then go from there. That likely a person coming in for first time syncope is not going to have these other causes with a very convincing story. So it's always like, if your story is not concerning, is this workup necessary, or can I come to a diagnosis using my history, using my physical exam, and doing some cheaper testing first?
So I love that that's part of the, what you're being taught and what you're experiencing and learning to do, because sometimes it feels like from the veterinary medicine side and like they just run all the tests all the time because like, of course, and it makes sense. But I love that really drilling down to those differentials and relying on the history and physical exam, because I think you can get a really good list of differentials if you run a million tests, but actually getting down to the true diagnosis takes that history and physical exam. So the fact that, it's not like, well, it could be this, your lab works normal, have a good day. Like you can really get down to a more specific diagnosis, if that made sense.
Yeah. So it's more like not saying like, oh, we're just chalking it up to this and sending you home. We're not going to do a thorough workup, but really just talking to the patient about, here's why I don't think it's this, and this is why this is reassuring. And these were things I'd look out for when you are home. If this does happen again, then these are extra steps we would need to take to be a little more thorough on what's going on, because it's happening more than once, so just kind of giving them the reassurance, but talking through it so they understand that you're like, I'm not dismissing this, but this is why I'm trying to be judicious with what I'm ordering.
Client communication, see another commonality we have. And also you being very good at histories is good when I call you in a panic and I'm like, am I dying? And good news, usually I'm not. Well, and we also saw your vet med skills came right back out just a minute ago, right before we recorded this. We did an annual exam, vaccines, blood work on your dog, and you just grabbed that front leg and rolled off the vein like a champ. And I was like, I forgot you knew how to do that. And we got blood and she was great. So those skills are still very much in place, and probably, I would say, much more advanced now that you do all kinds of procedures. So as an internist, what kind of procedures are you doing, maybe commonly on a day-to-day basis, and then maybe some that you're like, oh, I don't do this very often, a little more trepidation there?
So there's a lot of procedures that do kind of fall under that scope of internal medicine. I think the more specialized medicine is getting, the less a lot of internists are actually practicing these skills on a day-to-day basis. As trainees, we're encouraged to try to seek them out. But even so, as our training requirements have changed, it's not required that we do all these procedures and you are able to do them on your own. Probably some of the more common ones we do is paracentesis, thoracentesis, and then when we're in our ICU rotations, working with our critical care doctors, we do a lot of central lines and dialysis catheters and arterial lines in order to help get a little bit more access.
I'm just thinking about this because, okay, so when you say paracentesis, that would be what we generally refer to as an abdominocentesis.
Yes, yeah.
Okay.
So draining just acidic fluid from the belly.
I'm also, and this is kind of where I wanted to go next, was with specialization, because we were also talking about drains before we recorded this, because like I remember before I went to vet school placing like PICC lines and central lines, and not dialysis catheters, but definitely PICC lines and central lines. And we would do like sampling catheters on a regular basis, urinary catheters, but that's not quite as advanced. It's interesting, trainees and boarded internists, that's kind of like one of the procedures that they're like, make sure you learn how to do this, where maybe not always, but maybe it might be a little more widespread as far as like doing those skills in vet med, because human med just is a little more specialized in that way.
Yeah, I think we just have access to a lot of specialists, especially working at a large academic center where we're a tertiary referral service. So we have sub specialists in every field. So there's usually, and a lot of it comes down to just timing of your day, like doing these bedside procedures and getting all the supplies. It takes a lot of time in an already busy day. So if you can be like, oh, I can just send them down to our, radiology folks and they're able to do this procedure quickly because they bring people in and out all day doing the same procedure. So some of it's time and then also just comfort with the skills that you have.
And I guess, like if somebody, if we were to go like place the central line in a dog, like the dog's not going to look at us and be like, how many times have you done this? So, it's maybe a little bit more amenable to training and being able to practice that skill more often.
Yeah. And it's also just like where you're training, because like if in the ICU is where you'd be putting in the central lines, like as an internist, if I'm putting in a central line, they probably shouldn't be on the floor anymore. So they need to go to a higher level of care. So it's just by the time we get to the point of needing to do that, you're passing them off to somebody else.
I do not understand this system at all. This is why we have to keep having these conversations because I'm like, wait, explain it to me where they go next. How does this work? Which, we were talking before this about drain placement because I have this wound management case that I'm taking care of. And I was talking about putting in a Jackson Pratt drain. And we were walking through the procedure. You're like, well, I know what to do when they're already in. You squeeze the little thing. And I was talking through actually putting one in. And you're like, I'm not a surgeon, though. I don't do that. And I went, what do you mean? Like, this is a drain. And I'm not diminishing your skills by any means because I know that in so many ways, like your skills are way more advanced than mine in different areas. But the point of that conversation was you were like, well, a surgeon would place a JP drain, not me as an internist. And then we were talking about doing centesis and you said para and thoracocentesis. And I was like, well, what about a pericardiocentesis? And you're like, but that's interventional cardiology. And I'm like, there's so many layers. So I guess to me, like thinking about it from the vet med perspective, it seems like it would be hard to like find your role with all of the different specialties and subspecialties. So how did that kind of shape out for you?
It definitely has been a kind of a culture shift, I would say, in medicine in general, where because it is so subspecialized that people are really quick to just consult someone or a different service to help with things. And I mean, to a point, it makes sense. We have experts, they're here, they're willing to help, get them involved. But there's also that, like as an internist, part of the reason we go into that is you love being able to kind of be the jack of all trades and be able to start the work up for everything and have some idea of where to go with things. So you want to take some ownership over it and like be able to do that yourself. But it definitely has been, I think, more of a shift where you're seeing a lot more consultants involved in cases for problems that maybe previously would have been an internist would felt really comfortable handling.
So then my next question, of course, is like pros and cons to this subspecialization.
So I think in some ways, yeah, it's good because you have experts who are very knowledgeable on this thing, but I think you also lose some of the, forest through the trees kind of aspect where, you call a nephrologist and they're just worried about the kidneys. And well, not saying that they don't take into account the whole patient, but as far as their understanding of how everything's interplaying may not see it as much as they're seeing everything in perspective of how it plays into the kidney pathology that's happening. Whereas an internist, we're more likely to step back and kind of see everything that's going on at once. And maybe there's two problems. Maybe the kidney problem isn't the primary focus right now. And we may need to do something that's going to be a little bit damaging in order to fix something else and trying to balance, that all of the systems together versus seeing everything through the lens of it's stemming from this organ system.
That makes sense. And I can see like why internal med would be hugely appealing. Like, I'm like, yeah, I want to do that thing. Like, I want to know all the systems and put all the pieces together and make it play together, which you and I have both joked. I'm not an internist, of course, but I do enjoy those cases about how we've made wonderful careers about doubting ourselves.
Yeah. So people don't know, internal medicine doctors are the nerds of the medical field. Like we're the ones who are just like, think it's really cool and want to talk about all of the pathology and how interesting it is. And everyone else is like, we could do without the hours of talking about whether or not we're going to give diuretics.
Yeah, but like that's like, I mean, especially I like endocrinology a lot too. And like all the different pathways. And I'm like, and this goes here and it triggers this and da. And I like love nerding out over that stuff.
Gotta love a good feedback loop where everything's so bad.
Yes. And you're like, look, and then it does the thing. And so then we intervene at this part of the feedback loop and here we are. And I don't know how well everybody can hear who's listening, but we have Lisa's dog Shiva here, and she just got vaccines and she has big feelings about it. So she's singing to us in the background from time to time. She's exploring the office and the studio and singing.
Yeah, so if you hear some whining in the background, she's complaining about her vaccines.
Yes, she says she did not pre-approve us to give her vaccines today. So I guess then looking at it from a vet med perspective, we are moving more towards a specialization model. There's, certainly like, generalists, especially in certain areas, we still handle a lot and play that jack of all trades role. But we're also seeing more and more specialization. So with that being the case, like with your experience with this great degree of specialization, do you feel like, is it like a no, don't move towards specialization? Like you stay generalized, be able to do all the things. Is it a yes, continue to move towards it, but there's like a happy medium where you have to stop? Or is it like, no, ultimately, like this would be, the more specialization, the better?
So I think it's hard to say. I think it's happening regardless. And I think it's kind of a natural tendency as people have interests and we get more knowledge, and the doubling time for medical knowledge, I think they say is something like 5 years.
Yeah.
So it's an insane amount of knowledge that's happening. So to stay upfront and to really be knowledgeable on everything is nearly impossible. So I think it's only natural that we end up having a lot of subspecialization within the fields. So it's hard to say if this is a good or a bad thing. I'm sure there's benefits and cons to both, and there probably is a happy medium, and we'll probably swing too far before we figure out where that is, as we do with most things. But because even in subspecializing in like different fields, there's people who do extra subspecialization after that, and that's like a constant question as you're going into further training with fellowship is like, well, not only do you want to be a general, whatever your fellowship is in, but what area of focus in that field do you want to do? And that's becoming more common. And then kind of getting yourself this niche position that it may limit your mobility to move throughout the career, because how many spaces are going to have a need for that many super subspecialists in one niche disease process?
Absolutely. And so you're doing a little bit of, is your end goal, is that what we would call like a subspecialization? Because you're an internist but you want to do pulmonary critical care.
Yes. So that's a subspecialization under internal medicine. A lot of the specialists in medicine are internal medicine trained. So you do 3 years of internal medicine, and then you subspecialize in cardiology, GI, pulm crit, nephrology. So all of those were internists who did that and then went to further training in fellowship.
Okay. I think there's some similarities in some of our programs in vet med as well. Yeah, she's going to come out like triple boarded when she does her fellowship. She's the overachiever of the family.
Pick too many school things.
I mean, school is so fun though. One of the things that, talking about this subspecialization that we've talked about with your career is systemic change is the word that you've used. We've all had our frustrations with the human medical system, and and you've dealt with some of those frustrations from the physician side. So I guess, is your goal still to, kind of move up, not in a like striving kind of sense, but in a getting into a position where you can have more influence and help to improve the system? And if it is, which I think it is, what do you picture? And of course, that picture can change over time, but like if somebody puts you on the spot right now, which is exactly what I'm doing, what do you see that looking like?
Yeah. So I think my interest in kind of trying to help the healthcare system started before I even started med school. Previous to this, I was working at a job where I was a complex care coordinator for workers' comp, which is a big title to say. I was another middleman that was managing care between patients. And like, you're doing your best to try to advocate for the patient, but you're caught in a system that's complicated and unnecessary and has a lot of layers. Like there may be 7 steps between a doctor says the patient needs something and I can actually give it to them. So I think it was like, this system seems inefficient and kind of clunky, and we've got to be able to do better than what we currently are. And then actually getting into medicine and seeing, well, that's definitely true. And I'm sure everyone who's tried to navigate the US healthcare system has had frustrating experiences where it's not as fluid or as easy as we think it should be. And I think a lot of that comes down to is physicians need to be empowered to help advocate for change and to what do we think is good systems? Because I think the doctors themselves are not necessarily like, we would like it to be more patient friendly for people to have better access to care. Like those are the reasons we went into medicine. And I think it's kind of previously been where physicians kind of stayed away from administrative roles. and really focus on, well, I'm a clinician, I'm here to take care of patients. But I think unless we have people who are kind of willing to do both and say, hey, this is what it looks like when I'm actually caring for the patient, this may be a better policy for how we can adjust our healthcare system to be more effective to take care of people and easier to navigate, that we may not see those changes. So, well, the more I learn, the more you realize how convoluted and complicated actually making any of those changes is going to be. Even if I can get into a position where I can help affect change even at my hospital level or department level, I think that's kind of where I've set the goals on, is like, how can I affect policy and change in my own institution, which hopefully, could be adopted out and be bigger than that in the future. But for now, it's how can I make the process better for the patients I'm actively caring for, and not just the patient in front of me, but everyone who's coming into our healthcare system.
It's interesting because some of the things that you're saying, despite the two systems, veterinary medicine and human medicine, and specifically referencing the US here, I'm glad that you mentioned that. They're vastly different, but some of the challenges that you're talking about here, like we experience that on the vet med side too. Like access to care is a huge topic of conversation right now because cost of everything has gone way up. And it's how do we fit in the cost of veterinary care where we can still pay people who work in this field and obviously pay our bills, keep our practice open, but still make it accessible to people, and and the entry of insurance and pros and cons that we see there. And there's a lot of layers there. So while it's certainly not the same system by any means, some of the challenges are not dissimilar. And I'm thinking of what you're saying with these 7 layers to get from A to B. I'm like, tell that to anybody who complains that they were at the hospital for 3 hours when we did an exam, we did blood work, we interpreted the blood work, we did x-rays, we interpreted the x-rays, we got a plan together, we filled medications and all of this. I'm like, you wouldn't even be able to do that in the same building in human medicine.
Yeah, you would still be sitting in the waiting room of the ER. Yeah. No one had seen you yet.
Exactly. Well, let's, that we're kind of covering some heavy stuff here with, systemic change and everything like that, which I don't want to veer away from that topic if there's more to talk about there, because it is really important. But we can also kind of move to some lighter stuff here. What's your favorite thing to do? What if you get to do something that day, you're like, this was a good day.
As I said, internal medicine doctors are nerds. So if I get to really sit down and I have a patient who's super interested in learning the pathophys of their disease and why this is happening and want to be really involved, and I can spend a good amount of time teaching, I love doing that. So when I can really feel like they left with understanding of what's going on and how they can take their care into their own hands, I always feel like I left accomplished for the day.
No, so I feel the same way, not so much about the feedback loops, because you absolutely put me to shame when it comes to explaining feedback loops and all the different interventions that you can do. And then I have to just make a face and be like, whatever, I can put in a JP drain and you can't. So, but I do get excited about cat nutrition, which sounds silly, but think indoor cats, right? And they're, they get stressed because they just live indoors all the time. And so there can be all kinds of different dynamics with them. They get fat. And so then they get endocrine, other secondary comorbidities, which is usually endocrine disease. And so I love to talk to people about how to appropriately feed an indoor cat to help keep it a healthy weight and keep it mentally stimulated and all. I get so excited because cats are tiny aliens. And the more I learn about them, the more I'm like, these things are so cool. But you can see when I start to go into that spiel, the technician I'm working with, their face is instantly okay, I'm going to be here for a minute. And then I try to be respectful with owners and read their body language. And if they're just whatever, I just want to feed my cat what I'm feeding, just kind of, let it go to the point that they want to hear it. And then, give them an out and say, why don't we think about this little change? Or, if you don't want me to continue, that's okay. And let them out there. But every now and again, I get that unicorn owner who's no, tell me all the things. And I'm like, I will tell you all the things. And I'm like, you're going to have to tell me to shut up because I get real excited about this. And usually there's snickering from the corner from the technicians. It's yeah, you shouldn't have let her go with this. But yes, all that to say, I can absolutely relate to when somebody wants to listen to me go on about nonsense for, and tell them all the things I know, I get very excited.
Yeah, it's so much fun when you find like that person who's equally as excited and you're like, no, but this is really cool. And I need to explain to you why, so you understand why this is so interesting.
Like effusions, I also get kind of excited because I'm like, there's the colloid and then there's the osmotic and they work this way. And then these things affect it. And usually like, that's when the eyes glaze over and I'm like, isn't this cool though? And they're like, no, it's not.
I do also love effusions.
Yes.
So
And then like,
good
is it a
time.
transitate or, yeah, I love the nerding. This is
internal medicine, bunch of nerds.
Absolutely. Absolutely. So alternatively, what is like something that you see when you're like, gosh, that's going to be on me. I'm going to have to do that. And it's kind of like intimidating and causes this trepidation.
I think a lot of times, because I'm a people pleaser at heart, and I think that goes pretty well with a lot of people in medicine or in regardless of what you're doing, is you're doing it because you want to help others. So whenever you have something where you really want to help and do this thing, but you just can't, and having to go there and know that people are going to be like frustrated or you're not going to be able to help them in the way you would want to, or that what they're asking for just isn't reasonable, having to be that person to be like, listen, set those expectations of what I can actually do. That's never a fun conversation. It's always like, deep breath before you walk into the room. Like, I know this is probably going to be hopefully not argumentative with the patients or frustrating, but trying to navigate some of those difficult conversations when you're trying to set realistic expectations, if that makes sense.
So can you give us an example of like, just like a very vague type of scenario that would be the case?
Yeah. So like sometimes we're like I said, I work at a big academic center. So we get patients who are sent here from other hospitals. And sometimes we're not there for those conversations. And I'm sure everything was said with good intent, but what they take away from what they expect us to be able to do for them when they get here isn't always on the timeline they would like or what they thought they were coming to get. So they'll be sent over here for a procedure, and then our people will take a look and say, okay, well, we can't get them on the schedule till Tuesday and it's Friday. And I get to be the one who walks in and says, so you're going to spend the weekend with us. Like there's nothing I can do for you over the weekend. We kind of just have to wait until that person has availability. And so it's kind of that setting that expectations for the timeline and dealing with those frustrations when our system isn't quite as efficient as they hope it would be.
But I think having that trepidation around those difficult conversations probably helps you deliver it in a really empathetic way. Like nobody likes difficult. Well, I don't think very many people enjoy difficult conversations, especially like with that people pleasing nature that I can certainly relate to. I have noticed that they've gotten significantly easier over time because I've just gotten into this headspace of, whether it's a scheduling thing or, whatever it may be, of just really coming from a place where I know this is not on me. Like I don't make the schedule. I didn't, and the other people are important too. The other animals are important too that need to be seen. So this is not on me. It's just on me to deliver the news. And this person can get mad at me, but I'm not going to internalize that because it's not my fault. And really take a deep breath before I go in and come at it from a like, okay, if they're frustrated, it's understandable. Like I would be frustrated too, but that's not my fault. I don't need to internalize that. And it's made it a lot easier to approach those difficult conversations as time has gone on, which I think is purely like a product of you just have to keep having them. And they're never fun. They're never easy. I'm never like, yay, difficult conversation. I'm skipping into the room, but there's been a lot less like adrenal squeeze before I go in.
Yeah, no, it's definitely one of those things that I feel like it gets easier with practice the more times you have them. It's just one of those things you have to do again and again. And hopefully each time you do it, you get a little bit less of that, like, this is not something I want to do today.
Absolutely. Absolutely. So I think what I've taken away from our conversation here, which I take away from many of our conversations, is there's certainly differences between human med and vet med, but it also sounds like there's a lot of similarities to maybe not so much in like the systems themselves, but certainly in the medicine and the approach of many practitioners and, whether it's medical practitioners, veterinarians, technicians, assistants, and then, I don't know, what are all the layers in human med? There are lots of layers in human med too.
But yeah, no, I think there's a ton of overlap between the two fields. And as far as like what the actual medicine looks like, so it's always one of my favorite people to call and tell about something interesting that happened, because I can speak in full jargon and not have to stop and explain things, but you haven't a ton of experience in human medicine to fully understand it. So it's so exciting and fun to talk about. And I feel the same way when you call me about stuff. I'm like, oh, I understand that, but it's a totally different scenario. So
same. I feel the same way. That yeah, I have certainly like called you about some cases, and it is fun to like walk, because we do like we come at it from different perspectives. Me from like I'm a generalist, so certainly like there's a lot of knowledge that has dropped off over the years just from not needing it, and then to call you who has this like super specialized, like I say specialized, but it's not specialized because it's internal med. So it's all the things. So not specialized, but just very deep understanding of so much of what I'm talking about that, yes, we can speak in jargon, and you always have like a different perspective. Like I think I was talking to you about like a mass in a cat chest one time. And I was like, I was worried it was a bulla, but then I was like, why does this cat have a bulla? And then you started asking me questions just from a perspective like I didn't even consider, and things I hadn't even thought of. And it kind of shaped the way I came back at that case afterwards. And I don't know, I hope it's like the same thing.
yeah, definitely vice versa with things of like, well, did you think about this? Or like if I, because it's a lot of the same stuff where it's the medicine is the same. The approach may be a little bit different, but when you get to the end, the disease processes and kind of the workup and treatments, a lot of it overlaps, and having a little bit of a different perspective is really helpful. And I think helps you think a little broader when you go back to look at a case.
Absolutely. I think Shiva is having big feelings again and telling us to wrap it up here. But Lisa, this has been so much fun. I mean, like I said, we have these conversations all the time, and I always enjoy them, whether we're talking about kind of like we're talking about here, comparing human med versus vet med, or talking about cases themselves. It's always fun if you and I get the chance, like maybe we're both alone in the car at the same time, and so we can nerd out and talk in jargon and go over cases. And this is how we're big nerds, because when we get the chance to talk, that's what we're talking about. But I'm so glad that we can, bring it to listeners out there and, bring that perspective on human med, because I do think you bring a really good perspective. And I always love hearing your thoughts on the medicine, the approach, the thinking behind it and all of that.
Yeah, well, thanks for having me. It's been super fun, chatting about things we talk about constantly on the phone, and doing it in your space where, you're this big fancy podcast person now, and getting to see you in this role is really fun for me. So
I'll never be triple boarded though.
Well, we'll see. We haven't gotten there yet. We got to work on the first one first.
Fair enough. Well, thanks again, Lisa. This has been fun.
Lisa, thank you so much for coming on the podcast and joining me. I know I kind of put you on the spot here, so I appreciate you agreeing to let me put a microphone in your face and give us your perspective. It was really a great conversation. I hope everyone out there enjoyed the episode as much as I did. If you did enjoy this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassi DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.